Thank you. Okay, so today we're going to talk about the immune system. And a lot of what we're going to talk, some of what we're going to talk about is building on other courses. And some of it's going to be new content. Or again, we're going to be looking at it at a more advanced level. Let me see if that angle's okay. As I said, I'm in a different place. I'm at my old house. Okay. So when we talk about the immune system, the first thing we'll talk about is immunocompetence, which isn't all this beginning part should not be new to you. It's just a review. Melissa, I've let you in multiple times here. Okay, so the definition of immunocompetence is an intact and responsive system. And that's a really important word, response. Because when we talk about how your immunity in your body, it is a response. How do you respond to when an invading antigen or an invading foreign antigen enters your body and a foreign protein enters your body? Do you respond not enough? Do you respond appropriately? Or maybe do you respond too much? And so how does your body respond? And that's the whole key. What kind of reaction do you have? And if it is intact and it's working properly, you're said to be immunocompetent. And so that's the whole definition, but it's your response. How do you respond when you have this invading organism come about? Now, it can be lots of different kinds of organisms. It doesn't have to be a bacteria. Let me put you all to the bottom here. Okay. It doesn't have to be an organism. It doesn't have to be a bacteria. Often it is a bacteria, but it could be a virus. It could be a fungus. It could be a parasite. It could be a cancer. It could be anything tissue that's considered foreign to your normal tissue. And then how does your body respond when this foreign tissue gets inside your body? And so there's lots of things that can affect how your body responds. Again, chronic diseases, the more you've used your immune system, the less immune system you have. So it's kind of like you only have so much, and if you use it up, you don't have as much. So the best example of that I can give is you might say, I kept a cold all winter. It seems like every time I got rid of a cold, I caught another one. Well, that's because you just didn't have enough antibodies. You just didn't have, your immune system had been taxed or been used, and you just weren't able to fight when you got another cold. So the more diseases you have, or you're chronically using your immune system, the less immune system you have. The very old, the very young, and those with chronic diseases tend to have a decreased immune system. They just don't either produce enough or they're using it up, one or the other. Stress. Now, stress, it can be physiologic stress. Of course, physiologic stress, the most highest physiologic stress on the body is surgery. The second most highest stress is illness. Psychological stress to some degree, but not as much as physical stress. I guarantee when you all wrote care plans in 151 or when you had to come with verbal care plans to different courses, I guarantee that if you had a surgical patient, every single one of you all put risk for infection on there. And you probably did it because they had a cut. They had a break in the skin, which is absolutely true. But in another sense, it is true, but it's not because of the break in the skin. But when the body undergoes stress, whether it's physical stress or whether it's psychological stress, your bone marrow does not produce as many white blood cells. Therefore, just the fact that you had surgery puts you at risk for infection, not because you have a cut in your skin, but just for the fact that it is a normal body response not to produce as many white blood cells. The person in the psychiatric hospital that has true psychological stress does not produce as many white blood cells, and they tend to get sicker than people that aren't psychiatric patients. Those of you in nursing school, do you say, I've been sicker in nursing school than I've ever been? Well, right now we're in COVID, but is it because you're staying up late and studying, or you're trying to cram and stay up all night? Those of you that maybe were in college before and you stayed up all night cramming, and then what'd you do? You caught a cold 2 days later. You got the flu 2 days later, because your body, when you're stressed, does not produce as many white blood cells. It is a proven, scientifically based fact that when you are under stress, you tend to have more decreased white blood cell production, so your immune system does not work as effectively. And then medical therapy can affect you. We know chemotherapeutic agents are immunosuppressants. We know that steroids are immunosuppressants. We know that antibiotics and antivirals and antifungals help fight your infections. And so they help with your immune system. So there are some drugs that help immune systems, and there's some drugs that suppress your immune system. So it all depends on what that therapy is. So sometimes medical therapies help and sometimes they don't. So, come on, baby. So immunity is the state of responsiveness to the invading organism. How do you respond? Appropriately, too little, or too much? Immunity is your state of responsiveness. Now, this is pathophysiology, but it shouldn't be new to you. So how does your immune system work? Well, it does three things. It resists invading organism. It will fight your invading organism. It'll beat them up. And then once it beats them up, it digests them. It eats them to get them out of your body, phagocytosis. And then it remembers them. It remembers them. So this is just one of those little slides that are in like the memory book. So this FA is your foreign antigen. It's a foreign protein that is coming to your body, and it's there to cause tissue damage. It's there to cause damage. Now, these little things around here that have an A on their hat right here. Y'all can't see. I'm pointing to the wrong thing. So this is your foreign antigen. This is your foreign antigen right here. This is your protein. These right here, they have little A's on their hats. They are called antibodies. Antibodies are just a fancy word for white blood cells. Your antibodies are certain kinds of white blood cells. And so what they're doing, they're circling around this foreign antigen because they're going to get ready to attack it. You can see this guy has a knife right here, and he's going to attack it. So they attack the foreign antigen. Once they surround it, attack it, and beat it down, they're going to eat it to release it from your body. But before they release it, they're going to remember it so that next time the same foreign antigen enters your body, they're going to attack it sooner, and they're going to attack it with greater force. So that's what they mean by surveillance. So just because someone did not have a reaction to penicillin last time doesn't mean they won't have it this time, because maybe their attack of penicillin you didn't really recognize it, because maybe it was just a couple antibodies that attacked this penicillin. So maybe you didn't see much of a fight. But the next time when penicillin enters the body, more antibodies are going to attach it, so you might see it. I'll give you another example. Poison ivy. Maybe you can say, when I was little, I could handle poison ivy and I didn't even break out. And now all I have to do is look at poison ivy and I break out all over. It's typically each time you are exposed to something that you are allergic to, your response will typically be worse each time, because more antibodies are recognizing the foreign antigen and are attacking it. So just because you say you've never been allergic to something doesn't mean you're not allergic to it. We always have to be very careful. So when we give something that's parenteral, typically PO doesn't typically cause a lot of problems, but when you're given an IV or an IM antibiotic to somebody, we usually keep them in the office like 20 to 30 minutes to watch them, because just because they said they weren't allergic to penicillin before doesn't mean they won't be allergic this time. Or if you're giving them Rocephin or something like that, doesn't mean that they aren't going to be allergic to it this time. So you want to watch for signs of an allergic reaction. And my husband's been taking allergy shots for, God knows, he's old as dirt, so who knows. So I imagine he's been taking allergy shots for at least 20 years, I'm sure. I'm sure he's probably been taking them longer than that. And he goes to the allergist and they say, okay, as soon you need to sit down and you need to wait for 20 minutes after your shot. And he would no more wait 20 minutes than the man in the moon. He walks right out of that office. And I said, well, Michael, at least wait if it's a new bottle. Because if it's a new bottle, they're giving you a new foreign antigen or more foreign antigen. So at least if it's a new bottle, wait. Because I will tell you as an ER nurse, and I think I remember 3. There might have been more, but I remember 3 people that were brought in full arrest from their allergist office, and we didn't get any of the 3 back. And none of them were new taking allergy shots. But they were in full arrest, and they died from taking allergy shots at the allergist. Now, I'm not saying don't get allergy shots. I'm just saying when they say stay, you need to stay, and you need to be watched for any signs of an allergic reaction. Because whenever they introduce a new foreign antigen, you have an increased chance of having an immune response, a hyperimmune response. Now, autoimmunity is when your normal body proteins have mutated or have changed for some reason due to chemicals or due to a tumor or due to something, but your own tissues have changed and your body perceives these tissues as foreign. And so they start to elicit an immune response. So it's not an invading organism as much as your own tissues have changed their normal makeup. And therefore, the body perceives them as foreign, and they are giving you some type of an immune response. And that's autoimmunity. Your body acts like a foreign antigen when really there isn't a foreign antigen there. But the body is still doing a response to your own tissues. Now, an antigen is a protein that will elicit an immune response. And the surface is going to be slightly different than your body's own protein. And some common antigens. If I was in class, I'd ask you to name some of them. But things like eggs and bee stings or snake venom or pet dander or dust or peanuts or any kind of tree nut, like walnuts and that kind of thing, are really bad. Grasses, mold. There's hundreds of things. But those are medicines like chloramphenicol is really bad. Penicillin is quite bad. Aspirin is quite bad. Sulfa is one that can cause an allergic reaction. Doesn't usually cause anaphylaxis. Sulfa usually causes just a rash. Rarely will you get anaphylaxis with it, but it does cause an immune response. People that are allergic to sulfa rarely get in respiratory problems at all. But these are some common antigens, and there's many, many, many more when people say that they're allergic to things. And many times when you ask people what their allergies are, they're not always allergic to all these. They will give you things that they have side effects that they don't like, but they're really not allergic to them. They simply don't like the side effects. So there's a difference between an allergy and the side effects. For example, I get so nauseous with penicillin VK, PO penicillin. I cannot take it, but I can take amoxicillin because it's in a capsule. So I can take amoxicillin. It doesn't make me sick, but penicillin VK. And one time someone said, are you allergic to anything? I said, well, I'm really not allergic to anything, but penicillin VK makes me really sick on my stomach. And they put penicillin VK on my allergy list. I cannot get it off of there. When I go for Medrex, penicillin is always on there. And I say, I am not allergic to penicillin. I can take amoxicillin. I can take IV penicillin. So I'm always worried if I have some sepsis of strep, and penicillin is probably the best thing they can give me. They won't give it to me. because it's on my allergies, but someone put it down because I told them it makes me sick on my stomach. And so it bothers me that it's on there. So just be careful when you say your allergies. A lot of drug seekers will put a lot of narcotics as their allergies, but they will leave some narcotics off, and you wonder, why have they put all these narcotics? Because they are addicted to those narcotics, and you will never give them enough narcotic. If they've been taking morphine, for example, and if you want to give them 2, 4, 6 of morphine, and they've been taking 20 to 30 milligrams of morphine every 2 hours, you in the hospital will never give them enough morphine to if they were in a bad car accident, you will never give them enough morphine. So they will put morphine as an allergy so that you will not give them morphine. You will give them something besides morphine, something that will help their pain, like fentanyl or something bigger, because you will never, ever, ever give them enough morphine, because we would give a therapeutic dose of morphine and it won't touch them. So a lot of drug abusers will give you narcotics that they're addicted to on there because you won't give them enough medicine. Okay, so the different types of immunity, you've had these before. I know you got them in peds, you got them in OB, and you're going to get them again in 202. Do you have to know them? Yes, you do. Okay, now there's different kinds of learners. Some of you are linear learners. Some of you are more kinesthetic learners, where you like to see words. So this is a kind of linear. It's drawing of lines. I happen to like the line type of person. Some of you like words. So there's this picture that I'm going to keep up here. And afterwards, most of you will want to go to this. I've got each one of these explained on a slide that follows this. So most of you will want to go on to the papers, the slides that follow this. Okay, so we're going to explain this, but you can see how these types of immunity work. And I do better with lines than I do with words. Okay, so this little graph thing here really helps me. All right, so you might want to go to the next slide that's on your paper here. So you have two types of immunity. You have natural immunity and you have acquired immunity. Now, natural immunity is your natural resistance. Just what's your body makeup? What's your innate makeup? So it might be based upon race, for example. While this can have some crossover, for example, sickle cell disease. Typically, we do not see sickle cell disease in the Caucasian race. We see it in the African race and in the Middle Eastern race more than we do in the Caucasian race. However, my grandchildren are biracial. And so when my son took them in for their checkup, they asked my son, they said, we're going to test your children for sickle cell disease. And my son said, I don't think they'll have sickle cell disease. He said, I'm Caucasian. And they said, I know, but you don't know if you have any African American in your heritage. Therefore, that gene could have been passed right along, and your children could have this. And so we say that that's innate, but you don't know that. There could be a lot of mixing of this. And so, race could be it. Genetics, for example, hemophilia. We only typically see that in men and not in women. But, genetics could be a natural immunity. Species. We don't expect for humans to get feline leukemia. We don't, there's certain species that are very prone to certain diseases, and humans may not be prone to those diseases. So this is just your natural immunity. Along with that, it could just be your family's resistance. I don't think anyone in my family has ever died of cancer. Well, I just had an aunt die 2 days ago. And she died of cancer. And she's like the first family member that I can think of that ever died of cancer. She had lung cancer. She's not a smoker, but she had lung cancer. And she may be the first family member that I know of that is in our entire family that has ever had cancer. But I had 3 uncles on my mother's side, her 3 brothers, all died of hypertension and cerebral hemorrhages. And all 3 of them were 40, right on the nose. They all 3 dropped dead at 40. I've had hypertension since I was pregnant with my first child. It's treated But do I think my problem is going to be a stroke, hypertension, cardiovascular disease? I do. I don't think I think my innate is against cancer and towards the cardiovascular side. Do you have the BRCA gene? Do you have certain genes that make you more prone to things than your family? And so that would be your natural type of immunity. Now, acquired means that you have antibodies. You developed or there are antibodies in your system against the disease. That is exactly what acquired means, that there are antibodies that have been that came up after the disease, or there's antibodies. Acquired means antibodies. Okay. Now, under acquired, they can be active or they could be passive. All right. Active means that you yourself developed the antibodies. You put them in your body yourself and developed these yourself. Natural means you got the disease and you developed the antibodies after you got the disease. The most common one of this is chickenpox. In my age group, we got chickenpox. We dealt with chickenpox. We got the rash. We got the itch. And when chickenpox went away, we developed the antibodies to chickenpox. With natural, active, acquired immunity, you have lifelong immunity against the disease. I never have to get any kind of shots against chickenpox. Measles is another example. If you have measles, that's an example of that. There's lots of different ones for that. But you caught the disease and you have lifelong immunity against the disease. Artificial is you took a vaccine and you developed antibodies because you took an artificial vaccine. And you have immunity for about 5 to 10 years. And in 5 to 10 years, I'm going to close this door. The kids are coming out. In 5 to 10 years, you will need to take another booster to produce antibodies again. Now, some of you probably took a chickenpox vaccine, depending how old you are. My kids are in their 30s, and I think my oldest is 35. And they both got chickenpox, but it was right after that. So if you're in your late 20s, you probably got a chickenpox vaccine, or maybe right at 30, you probably got a chickenpox vaccine. But if you're in your mid 30s, I bet you got yours from getting chickenpox. So, chickenpox you might have got a vaccine. All of you had MMRs, measles, mumps, and rubella. And so MMRs are a vaccine. That's acquired. You got antibodies. You actively built those antibodies, but you got them artificially through a vaccine. Your polio vaccine. You took polio vaccine when you were an infant so that you didn't develop polio. Your tetanus shot. You get a tetanus shot every 5 to 10 years after exposure to dirt or any type of trauma to the skin. Tetanus is life-threatening. You will probably die if you develop tetanus. So if you have a break in your skin due to trauma, you need to get a tetanus shot every 5 to 10 years when you have a break in the skin. So all of those are artificial, active, acquired. You got the antibodies, but you built them actively inside of your body. Okay. Then you have acquired passive. Acquired means antibodies. Passive means you didn't build them. You just were given them. Somebody or something just gave you the antibodies. You didn't build them. You didn't actively produce them. Somebody just gave them to you. Naturally, your mother. Your mother passed antibodies to you through her placenta and through, if you were breastfed, through your breast milk, through her breast milk, through her colostrum. If you weren't breastfed, you still got them through the placenta. And you will keep these antibodies as long as you're breastfed, or if you aren't, for about 3 months after your delivery. You have immunity to whatever your mother was immune to. If your mother never had a polio vaccine, she probably did. But if your mother didn't have a polio vaccine, then you're not immune to polio. And it'll only last about 3 months. And then you will start getting your immunizations as a baby. Okay? But those are, you'll get the antibodies that your mother has. And then acquired, you got antibodies. Passive, somebody just gave them to you. Artificial, you go to the infusion center or wherever, and they start an IV on you, and they give you a bottle of antibodies. It's called, the late term we use is gamma globulin. It's called IgG, which is gamma globulin, intravenous gamma globulin, gammas.
Jamie.
Yes.
Madison got kicked out. She's just sitting in the waiting room. I'm sorry to interrupt.
Thank you. Thank you. I didn't see her. I was there talking. Thank you. Okay. So you just get them by IV. Typically, these are people that have some type of immune disorder, cannot produce any antibodies on their own. And so about every 6 weeks, they go in and they get some antibodies given to them IV. And it takes about 6 weeks for them to degrade down. And then 6 weeks later, they go get another liter or however much is in there. I don't know how much is in a bag. And then next 6 weeks, they get it again.
So the passive artificial only lasts for 6 weeks?
Typically, they last about 6 weeks. So about every 6 weeks, they have to go get a little booster of antibodies about every 6 weeks. Because they just can't produce it themselves at all. They can't produce, their bone marrow is just not producing any antibodies at all. Okay, so those are the different kinds of immunity. So I spelled all those out for you. For those of you that like it in words, and those of you that like it linear. I happen to be a linear kind of person. There's different kinds of learners. All right. So what about in your body? What do we have in our body? We have different kinds of tissues. So you got lymphoid tissues all located throughout your body, and they produce lymphocytes. Now, lymphocytes are special, or they're early kinds of white blood cells, okay? And what happens is your inside your bone produces these lymphocytes, right? And then, you got them all over your body. You got all different kinds of lymphocytes. And I want you to kind of look, I really like the next thing that's better, but you got all different kinds of lymphocyte tissue. So you got they're not just inside your bone, they produce inside your bone, but you've got helper places all throughout your body that help with your immune system. So you got your tonsils, special lymph tissue, lymph nodes, your spleen. All of these are part of your lymph system, part of your immune system. So I don't know if you think of your tonsils as part of it, but they are. That's all part of your lymph system to help you with your immune system. So the bone marrow produces all blood cells, red blood cells, white blood cells, platelets, all of your blood cells. Then it goes to your thymus gland, which is in your mediastinum, and your thymus gland says, oh, you're going to be a T3 cell. You're going to be a T10 cell. You're going to be a beta cell. Oh, you're going to be a white blood cell. You're going to be a red blood cell. You're going to be an erythrocyte. You're going to be this. Your thymus tells all of it what it's going to be. Okay. So that's what the thymus gland does. It tells it all what it's going to be. And then you've got this lymph tissue that's located around all throughout the body. And it typically, so look where these are: tonsils, gut, genital area, bronchial area, and skin area. Does anybody want to guess what's common about these 5 areas?
Places where antigens could easily get in, like your
Places where things get inside the body. Exactly right. Places where these bacteria, these viruses, these parasites, these bad things can enter the body the most. And therefore, they put whoever you believe in created the body. I don't care. I'm not here to argue about that. But however you believe the body was created, said, you know what? You know, I got this people that are going to be eating this stuff. I better put something in the back of the throat. That's where your tonsils sit. I got people going to be having sex. I better put some in the genital area to catch dirt put up through there. Okay. I got cuts in the skin. I better put it there. I got breathing. I better put it there. And, you know, when you think about where a huge amount of lymph nodes is in the breast area. Why? Because I've got a baby that's going to suckle around the breast, and the mouth is one of the dirtiest places on earth. And so it's to help protect the breast when the baby breastfeeds from getting their dirty mouth on the breast. And that's why the breast is so full of lymph nodes, because it's such a dirty, dirty, dirty area. And so it's all part of it. So that's why we put these lymph nodes. That's why the lymph nodes are there, to filtrate out foreign tissues. And so what happens is this foreign antigen enters wherever in the body, wherever it happens to be. The lymph node is a screen. It catches it. So rather than allow this foreign antigen to circulate throughout the whole body, and these antibodies are swimming, trying to catch it, you put it in a screen, it's stuck, and now the antigens know exactly where to go to find it. And then it's stuck in the screen, and they can surround it and attack it. And so that's the purpose. It's to screen it out, to filter it out, to keep it from going deeper. Therefore, it's going to catch it at the openings, and then the antibodies can surround it, take a picture of it, surveil it, and then it can eat it and get rid of it. When I was growing up, pretty much everyone had their tonsils out. You had a sore throat, they jerked your tonsils out. And I happen to still have my tonsils, which is very, very rare for someone of my age. And I would say, when I first started teaching 20 some years ago, I was in class, I would ask, how many of y'all have your tonsils? And I bet in a whole class of 60, 70, however many in the class, usually about 5 hands would go up. So, usually 40 some kids had their tonsils out. Up until, when we went on COVID, I would ask who's had their tonsils, who still has their tonsils, or however I want to ask it. By this time, 45 to 50 kids still had their tonsils, and only about 5 had their tonsils out. Because what we found was, don't take the tonsils out. Because if you take that screen out, well, then the foreign antigen has got to go down deeper to be caught. So all of a sudden, it wasn't bad to take these tonsils out. You leave them in. I mean, it was bad to take them out, leave them in. Now, if you kept a strep throat, not a sore throat, a strep throat, and they never could clear it up, they give you antibiotics, the strep would go away, and 2 weeks later, you had another strep throat, which really said you were keeping strep. You really weren't getting rid of that strep. Then your tonsils have to come out. But just because you have large tonsils, and just because you have a sore throat, is not a reason to take the tonsils out, unless they're carrying strep that you cannot clear up. Then they're going to come out. My grandson just had his out. But as a whole, you don't just take the tonsils out. If you looked in my throat, my tonsils are huge, huge. but I've never had strep ever in my entire life. So, you know. Okay. The spleen is the primary filtering system for the entire body. Pretty much it's your in deep filtering, your blood goes through. And it is so full of white blood cells so that if you get something circulating in your main bloodstream, when it goes through your spleen, those white blood cells just attack it. What time is it? Just attack it. So hopefully you don't get septic. It's your main source of filtration. And I've never worked in the OR, don't ever hope to work in the OR. But those of you that do work in the OR will love it, and that's good for you. That's why what's the nice thing about nursing. However, the doctors tell me that when they open up a spleen, there are so many white blood cells in a spleen that they call it white pulp, that it is white inside of it. There's so many white blood cells because it is just full of white blood cells. And so one of the things so they don't want to take these spleens out unless they absolutely have to take them out because they are very important for immune response, for infection prevention, or to catch infection when the patient has one. You can live without your spleen, but they need to be careful because they don't really have their main filtration of infection. They're at risk for sepsis if they get it. They go to get a strep infection, so they need to treat it promptly and take their antibiotics like it's prescribed and that type of thing, because they're going to lose their main source of infection, of filtration and immune response in their body. Okay. So this shouldn't be new to you either. Your bone marrow produces your lymphocytes, and then they differentiate into two types of cells, either B cells or T cells. Okay. B cells are called bursa equivalent cells. T cells are called thymus dependent cells. Now, B cells you learned about in 151. You probably learned them in 101, and I know you learned them in A&P. And I'm not going to talk very much, a little bit, but not very much about B cells. Bursa equivalent cells are what is released when a bacteria enters your cells. It's just by chance that bacteria and B cells start with the same thing. Okay, they're called bursa equivalent cells. But B cells are released when bacteria enters your body. And I'm making this part up, so don't write it down. I mean, I'm not making it up, but I'm making the number up. But it always amazed me that it says when a bacteria enters your body, it's something like 300,000 millimoles of bursa equivalent cells are released per second into your bloodstream to go after that bacteria. Now, I don't know what a millimole is, but 300,000 per second sounds like a lot to me. And it might have been 800,000. I don't know, but it was a lot. When I read it the first time, I thought, wow, that's a lot. So that should just say to you how much immune response your body sends out when a foreign something enters your body and how your body tries to kill it. Again, I don't know how much, I don't know what a millimole is, but okay, whatever. All right, so T-lymphs, we're going to talk about T cells in this course because you really didn't talk about T cells. So bursa equivalent cells are more with surgeries, more with bacterias and that type of thing, which happened more in surgical, which was in 151. T cells are for things inside the cells in humoral immunity. Now, your bone marrow typically produces about 70 to 80% of lymphocytes are T cells. Only about 30 to 20% are B cells. Again, is it because, I don't know, this is a theory. Is it because somebody, whoever made these, said, they're going to learn about antibiotics and we've got something to help with bacteria, kill bacteria. We're not so good about viruses yet. We're working on antivirals. We're not as good with viruses. If we were good, we wouldn't have COVID. We wouldn't have AIDS, but we're not as good. So why don't I make the bone marrow prevent more viruses by having the immunity against viruses? So in reality, your bone marrow produces more cells to fight viruses than it does to fight bacteria. It produces both, but it produces more against the virus. So the viral one, okay, or humoral immunity is for, I might have said this wrong a minute ago. Humoral immunity is when a bacteria enters the body. I may have said that for T cells a minute ago. I didn't mean that. I think that's what I said. Humoral is for bacterial immunity. It's when bacterial enters the body, okay? And so it elicits an immune response. Now, you all have heard of a CBC, of course, white count, red count, hematocrit, hemoglobin, and platelet count. You've heard of that. I know you have. And you've heard of a CBC with differential. I'm not sure you knew what a differential was, but you're going to learn today what a differential means. Because everybody knows what a CBC means. Do you know what a differential means? A differential says if the white count is elevated, it only has to do with the white count. Doesn't have anything to do with red count, hemoglobin, platelets, anything like that. It only has to do with the white count. If the white count is elevated, I will tell you what kind of white blood cell it is. And that will help you to determine what might be going on with the patient. So, on the differential, you might see monos. You see lots of things, but some of the most common are monocytes, gamocytes, eosinophils, and then you're going to have your neutrophils. There are other things that are on there, but these are probably the four most common that you need to know at this point, or for you. Okay. So when you get a bacterial infection, the first antibodies that are released, or that is released, is IgM. M stands for monocytes. So when your white count is, normal white count's 5 to 10,000, close enough, 5 to 10,000. You got a white count of 16,000, 18,000, whatever, your white count is elevated. You look at the differential and your monocytes are high. That will tell you that this is a new bacterial infection, and it's within the first week, 4 to 8 days, that this patient has had this infection. It is a new bacterial infection. Monocytes are released at the beginning of a bacterial infection. After about 8 days, after about a week, your white count has remained elevated, but your monocytes will go down to close to normal. They might be a little elevated because you might have more tissue getting infected. But your gamocytes, your IgG is going to go up, and because it is longer acting. So when your gamocytes are elevated, you have a longer acting infection. It's been there for a while. And the IgG is trying to get in there and neutralize the toxins a little bit different way. It just is something that's gone to attack longer standing infections. They work a different way. They're still trying to stick them together and eat them, but it just was working a different way. Okay. IgE, E stands for eosinophils. Eosinophils are released as a response to an allergic reaction. Eosinophils are antibodies. Eosinophils are white blood cells, but they are not due to a bacteria. They are due to an antibody antigen reaction, but not a bacteria. So if you have an asthma attack, your eosinophils might be up if it's due to an allergic reaction. Your white counts will be elevated, your eosinophils will be up, but you do not have a bacterial infection. Last night I was watching television and a commercial, one of those, you know how many drug commercials there are on TV, and there was something to treat your asthma due to eosinophilic condition, eosinophilic asthma attack. And I said, no one knows what that means, but what would an eosinophilic asthma attack mean? Due to an allergic asthma attack. Eosinophilic means allergic. You take it because of an allergic asthma attack. That's what eosinophilic means. It's an allergy, not bacterial, allergy. So your white count's up because it's still a white blood cell, but you don't have an infection. You have an allergy. Okay. Neutrophil. A neutrophil means you have immature cells, white blood cells, in your bloodstream. Why would you have immature white blood cells, you ask? Well, I will answer. When you have a chronic illness, your body is constantly sending out white blood cells to try to kill something. And cancer is a great answer, a great example of this. You talked about neutrophil in PEDS, because PEDS is where you talked about leukemia. So you've got chronic cancer, non-solid cancer like a blood cancer like leukemia. So your bone marrow is constantly sending out white blood cells to try to kill this leukemia, to surround it, kill it. But you know what? Leukemia is getting the better of the antibody. It's winning the battle. So all of a sudden, the leukemia is winning, and the bone marrow says, I've sent all I have. I don't have any more mature WBCs. However, to be mature, you had to graduate from high school. I have some 11th graders. They're not mature yet, but I got some 11th graders. Can they do anything for you? Well, yeah, send me some 11th graders. I think they can at least do most everything a person graduating from high school can. So when you see immature cells coming out, you know that the cancer or the chronic illness is still there, and the bone marrow has used up all the mature cells, and now they're having to send out immature cells to try to fight because the chronic illness is still present. If the chronic illness was still not present, then the bone marrow could stop sending out and they could start building up the mature cells again. But the minute you see immature cells, you know that the chronic illness is still there. And they're having to send younger and younger and younger and younger people into battle. Okay. So that is what a differential tells you. The white count tells you they got a white count of 18,000. Now, what kind of white blood cells are out there? It may help you in diagnosing what's going on with the client. All right, now get off there. Cell-mediated immunity. Cell-mediated is for the T cells, for things inside of the cells. Your viruses, your funguses, your tumors, transplant rejections, and your hypersensitivity reactions. This is that 70 to 80%. This is what most of the things that come out of your bone marrow is. So they are your mature T cells. We call those T cells. The two most common that we see are your CD4 cells and your CD8 cells. And we hear more and more about this, and we're going to talk more about these. Your CD4 cells are your helper cells. They are the ones that produce your antibodies on your virus side. They're the ones that are the antibody producers. They help to destroy these viruses, these things within the cells. CD8 cells are cytolytic cells or cytotoxic cells. Anything that is cytolytic or cytotoxic destroys the cell walls. They help break down the cells. So one's for helping to produce the antibodies, and the other one comes in and sort of attacks the cells and breaks them down, and the other one's producing more things that will produce the antibodies. So it's hitting it from both ends, I guess, for lack of better words. So there's different kinds of CD cells. There's CD3s or T lymphs, and then CD4s and CD8s are specific kinds of CD cells also. So they can give very specific jobs to CD cells. And we're going to talk more about these cells when we talk about AIDS in just a few this afternoon. Okay, so let's go on with this for just a second. So when we do a nursing history on these patients, asking questions are very, very important. What is their susceptibility to infection? If you ask me, I would tell you I pretty much never get sick. I am rarely sick. I hardly ever have a cold. I don't really get infections. I just don't get sick. I'm pretty healthy for the conditions I'm in. I'm pretty healthy. A good friend of mine used to teach peds. She's retired now, but I swear she was the sickest person I ever saw. She would have a cold, or she'd have a call in one day a week. And you're going to meet people that are always sick and those that aren't sick. And so what is their susceptibility to infection? Nutritional status. Maybe that's why I'm not sick. I'm a good eater. What is the nutritional status of someone? Are they cachectic? Are they somebody who doesn't eat well? Someone who doesn't eat well. What is their nutritional status of someone? How is their skin? Is their skin broken down? Do they have a lot of lesions on their skin? Do you see where they've been scratching? What does their skin look like? The skin is a great place for entry of bacteria. So look at their skin. What does it look like? History of childhood diseases. Ask them. Tell me about what childhood diseases. Most people can tell you if they had chicken pox or not. Most people can tell you when they were a child. I had leukemia as a child. They can tell you what kind of childhood diseases that they had. They'll know if they had whooping cough when they were a child. They will know these things. And then what kind of chronic diseases do they have now? They know if they have COPD. They know if they have diabetes. They know if they have lupus. They know what their chronic diseases are. Do they have an autoimmune disorder? Believe me, people with autoimmune disorders know they have them, and they will tell you they have them. Environmental factors. A lot of times you might just ask, where do you work? Do they work at the McGuire nuclear plant? That puts you at risk whether you want to believe it or not. It does. Yes, they have big safety factors in place, but they still have more exposure to radiation than some people do. Are you in healthcare? Do you go into the x-ray department more? I guarantee you do more than the average person does. If you're an ER nurse, I guarantee you have more exposure than the nurse on the floor does. Because we take x-rays in the rooms with patients all the time. Are you a flight attendant or a pilot? Every time you fly, it's about equal to one chest x-ray. It's a businessman that flies every day. Delta Airline did, it was in probably the 70s maybe, did a study and said, why are our flight attendants have a higher percentage of breast cancer than non-flight attendants? And they found about the radiation. The international was worse than domestic. Why? They flew higher and they flew longer. And probably Delta was the airline that caused the fuselage, the design of the fuselage to be changed to more protection against radiation for those that fly. So it's not as bad as it used to be. What medicines do you take? Are you on steroids? Do you take chronic antibiotic use? Did you take, what's the one for the acne? Starts with an A. Can someone tell me?
Accutane.
Accutane. You know, did you take Accutane? Maybe. It might cause problems. It might not. But we know it could cause bad birth defects. Maybe. I mean, what medications are you on? And what is your radiation exposure? Can it be a problem? And then we're really gonna look at their skin. Do you see any signs of infection? Do you see any skin breakdown on them? Actually, not just asking them, but looking at them. Check their mucous membranes. Do you see any lesions on their tongues? Do you see any breakdown around do you see hyperplasia of their gums maybe? But look for any signs of infection. Palpate their lymph nodes. As a nurse, there are certain lymph nodes that you should know how to palpate. You're looking for increased size and tenderness. You should be able to palpate sublingual nodes. You should be able to palpate here and feel a knot if they have anything from their lower jaw to under here. You should be able to palpate anything that's large under there. You've got 2 rows of cervical right beside your spinal column in the back. You should be able to feel that. If you came to me, it doesn't seem to be up today. I have 1 cervical node that stays pretty large. No, it's gone. I must be healthier. But I've had it checked many, many times and it's fine. But I would like, when someone does my exam, I'd like for when they say, oh, how long has this been up? How long has this been bigger? You should be able to feel any axillary nodes. You should be able to feel inguinal nodes. And if it's an AIDS patient, they will have what we call a regional node. It's very classic for AIDS patients. And it's right about at your bra line. Now, if you've never felt a lymph node, a true lymph node, and if it's inflamed, it will be big, hot, and red. But if it's just a lymph node, like from cancer, if you've never felt one, the best description I can give you of one is it feels about the size and the feel to me of a pencil eraser. Cut the little, I happen to have a pencil, not on purpose. But if this was a full-size pencil eraser and I cut it off right here, let's say it was full pencil eraser, one that hadn't been used, and you stuck that under the skin, that is exactly what a cancer lymph node feels like to me. So it's not big like a golf ball, but it feels like it's hard and it almost feels that way, like a pencil eraser would be underneath the skin. That to me is what it feels like, about that size. I don't think it's as round as a pea. I think it's more oblong-y to me. The ones that I have felt have been more oblong-y, like a pencil eraser would be. But you should be able, when you do a physical exam, to feel it. Yeah. It's really interesting. I have to tell you. It's been many years now, but I had to have a tooth pulled back here. I cracked a root and I kept it in there for years. I had a crown on it, but I knew something was wrong with it because every once in a while, if I bit down wrong on it, it hurt. And the dentist kept saying, "There's nothing you can do but have this tooth pulled, Janie." I don't want to have a tooth pulled. I'm a chicken. And then one day I had some problems in my mouth, and it was very unusual. I was on lisinopril and I had angioedema. It's pretty scary if you know the truth. And so they sent me to a oral medical doctor, not a surgeon, a medical doctor. This guy was impressive. Let me just tell you, this guy was impressive. I was impressed by him. And it's so funny because he's doing his exam on me and he said, "You're going to be okay." He says, "This is going to go right back down." But the under my tongue, this tissue under my tongue was hanging out on my lip. And it came just like that one day in the office. I was just like, "Oh God, what is this?" But anyway, so he comes like this, and he goes, "Oh man," right under that tooth, he says, "You have a bad tooth, don't you? You got a huge lymph node right here. Move your hand." "I don't feel anything." He said, You don't feel that lymph node right there?" I said, "No, I don't feel it right there." And finally, he put my finger right on it, and I said, "Oh, I do feel it," but I had not felt that lymph node on there. But he had to put my finger exactly on where it was. So but he was feeling a deeper one than just a typical lymph node. But I was like, "Oh wow, I'm impressed. I'm really impressed." But he knew exactly where to push. He knew exactly what to look. So you all should start to, when someone comes in like with a sore throat or a sore tooth or whatever, start where you know the abnormality is. Once you recognize the abnormality, you'll be able to recognize them when you do them. All right, y'all, it's 10:03. I'm gonna see y'all back here at 10:13, and we're gonna keep moving on the immune system. All right, I'll see you at 10:13. Okay. It's my desk. I don't have a desk here. To hold my laptop in my lap. So I guess that's why they call it a laptop, huh? Supposed to be on your lap. Well, that's where it is. Okay. So if someone has a suppressed immune system, how do we know it? I mean, how do we, you know, if they're not sick and they don't really feel sick, and how would we know if they have a suppressed immune system, or how would we know how would we know to guide treatment? Well, there's lots of things we can do, but one of the things is we try to elicit an immune response and see how their body responds to that. Because remember that your immune system is a response. How does it respond to a situation? And one of the ways that we do this is with our tuberculin skin test. Now, we don't do these every year anymore within Atrium Health, but we used to do them. And I know all of y'all have had tuberculin skin tests. So what is that? We put a little bit of tuberculosis under the skin with an intradermal injection. And if you have been exposed to tuberculosis, then that means that you have antibodies. And the antibodies will rush to that little tiny, tiny, tiny bit of tuberculosis, and it will surround it, and it will make it red and hot, and it will start to eat it. We call that induration. We don't really look at the redness. We don't really look at the hotness of it. We simply look at, hang on, I'm trying to get this thing to work again. We simply look at, did it get big and did it get puffy? All right. I can't get this thing to move. Come on, baby. Come on, you can move. Why are you not moving? Man, I gotta get the slide to move. Just a second. So what it is you had an immune response to that tuberculosis. Now, if you didn't have a response, does that mean that you weren't exposed to tuberculosis? Or does that mean that you did not have an intact immune system? I don't know. So we sort of go under the assumption that most people have an intact immune system, unless you have a reason not to have an intact immune system. And we talked about that. Very old, very young, chronic diseases, or taking a medication or something like that, then we might suspect that your immune system. But just because I look at you, or you know, I can see Jenna Rogers on my tape on my thing here. You know, just because I look at Jenna, I wouldn't suspect she has a decreased immune system that wouldn't be able to fight any kind of infections. But, you know, unless I suspected something, we would assume your patient has an intact immune system and would be able to fight infection. All right. But when you go with somebody that maybe you question, and you really need to know, were they exposed to tuberculosis or not? A non-reactive tuberculin skin test doesn't tell us a lot. It says to us, well, is it no exposure? Because if they weren't exposed, they won't have antibodies. Or is it a non-intact immune system? So what we will do is, if we suspect they don't have an intact immune system, we will do what is called controls. Now, controls are just like a control of an experiment. When you have controls in an experiment, the people that are in the control group, you know what's going to happen to them. So just like with controls, I'm going to put controls on my patient, and I know what's going to happen to the controls. They are going to have an immune response when I put these controls on them. So I put a tuberculin skin test in their left arm. You should always put your tuberculin. You never shake hands with TB. So your tuberculin skin test should always go in the left arm. Okay. So I put that 0.1 mLs on their left arm, intradermal. And then in their right arm, I put 2 intradermal injections. One is candidiasis and one is mumps. And I think everyone should respond to the mumps vaccine. If you're in the United States, you pretty much, everyone that has attended any kind of school in the United States has to have had an MMR. You could not have gotten in this school without an MMR. Even if you were homeschooled at home, before you could get into any college, you have to have an MMR done. So I expect everybody's mumps to be positive. You should have antibodies against mumps. So when I put that mumps in your arm, you should get a bump where the mumps is. When I get this bump, it tells me your immune system is intact. Almost every woman in America or every child has had thrush. So the candidiasis is usually positive too. So I expect my controls to be positive. They should have a bump about the size of a green pea. That means an intact immune system. With an intact immune system, now whatever the results of my PPD is, means it's valid. Okay, so I've been getting PPDs up until last year, I guess, every year since I've been a nurse, 40 some years. I've never had controls in my life. Why? Because I have no reason to have controls. There's no reason to suspect I do not have an intact immune system. I'm not on immunosuppressants. To my knowledge, I don't have AIDS. I have no diseases that would indicate that I have a decreased immune system. God knows I'm not cachectic. I'm not skin and bones. I have no nutritional issues. So there's no reason to suspect that I have a decreased immune system. Therefore, there's no need to give me controls. So if I get a TB skin test and it's flat, I have not been exposed to TB. If it's bumped, I have been exposed and I have the antibodies. That doesn't mean I have TB. It just means I have the antibodies. Now I need the chest x-ray and the AFB sputums times 3 to diagnose my tuberculosis. But if my TB is negative, I don't have the antibodies. I don't have it. Okay. All right. So hypersensitivity. When we're talking about altered immune systems, you can have like no immune system that doesn't work effectively, or you can have an immune system that overworks. It's an overreactive immune system. And this can result in tissue damage due to the overreactive response. And this is called a hypersensitivity reaction. And there's 4 types. There's type 1, type 2, type 3, and a delayed hypersensitivity reaction. So those are your 4. We're going to talk about type 1, type 2, and type 3. Type 4 are things you may not see for months down the road, and they can be things like hepatitis. Well, we are going to talk about HIV, but more like things that you might get down the road, not things that happen sort of immediately. So we're going to talk about type 1, type 2, and type 3. All right. So type 1 is IgE mediated. IgE means it is allergic reaction mediated. The most common is anaphylaxis. Anaphylaxis is a type 1 hypersensitivity reaction. It's not the most common, but it is in a type 1. We'll talk about the other in just a second. So the allergen, you get exposed to a foreign antigen, an allergen, a protein, a foreign protein, and it starts to produce eosinophils. And so you, on your chest x-ray, listen to me, on your CBC, your white count will go up because antibodies are white counts. But on your differential, you'll have an increase in your IgE, on your eosinophils. Okay. Now this allergen links up with the mast cells on your skin, on your nasal areas, and in your lungs. And this linking up causes a release of histamine, serotonin, and bradykinin. And it just is the reaction that happens when the allergen hooks up with your normal tissues. It's just what happens in this anaphylactic reaction. Now, when this happens and you get this histamine release and serotonin and bradykinin, but histamine's really one of the big problems, you get an increase in vascular permeability, a change in permeability at the capillary beds. How many times have I said that? What does that mean? The holes get bigger. Okay, that is what that means. So what happens? Well, a lot of things happen. The first thing, several things happen. One is you get laryngeal edema. So they get, the edema starts going out of their tissues and it starts to squish their larynx. And so they're going to have ineffective airway clearance. They get their larynx squeezed because of laryngeal edema. And this is all due to increased capillary permeability due to the release of histamine due to the exposure to a foreign antigen. You also get bronchospasms. You get a bronchial constriction. So they're going to start coughing. They're going to start wheezing. They're going to have shortness of breath. They're going to have difficulty breathing. They're going to be dyspneic. They are going to be hypoxic. They are going to have major shortness of breath. So they have an airway problem and a breathing problem. Not good. They also, because of the change in permeability of the capillary beds all over, fluid is seeping out of their circulating blood volume into their tissues. So their cardiac output is going to fall and they become tachycardic and hypotensive. Tachycardic, hypotensive, pale, cold, and clammy. So they go into an underperfused state and they are in a shock state, an underperfused state. That is why it's called anaphylactic shock. But they do have the respiratory component with it also. But they are underperfused due to the change in capillary permeability. Their face will swell, their hands will swell, their feet will swell. Histamine will release out with that fluid that goes rushing out into the tissues, and this histamine release will cause itching in their extremities, and so they'll start to itch all over, making me itch. They will start to itch all over, and it will cause a redness, and because of this capillary permeability, well, they'll be pale, cold, and clammy too, but the extremities can also get red with the itching due to the histamine, and that's typically at first. And then they will turn pale, cold, and clammy. They'll get red, then they'll get pale, cold, and clammy because the body's going to clamp down trying to increase their blood pressure. The histamine causes nausea because it increases your gastric acid production. Yeah, let somebody in. Their decreased blood pressure will cause weakness. And as I said, they'll have edema of their face, like they'll get edema of their lips, they'll get edema of their hands, they'll get edema of their feet. And all of that is due to a change in permeability of the capillary beds. So they're not all here. Ineffective airway clearance, ineffective breathing, ineffective circulation, alteration in comfort. They got a lot of itching, and the itching is really is driving them bananas because they're itching all over. And they are anxious. They are anxious. They are hypoxic. They are very anxious because they know it is bad. Typical causes of anaphylaxis: drugs can cause it. The most common drugs are penicillin, chloramphenicol, aspirin. Those are the three most common things that cause anaphylaxis.
What was the second one called?
Chloramphenicol. CHLOR. I think it's AN. It could be AM, but I think it's AN. PHENOCOL. Chloramphenicol. It's an antibiotic. Chloramphenicol is an antibiotic. And aspirin are your most common. Allergen extracts. So that's like allergy shots, because they're giving you what you're allergic to. It's desensitization. It's what you're allergic to. They're giving you a little bit of what you're allergic to so that you build antibodies. Okay. Foods, eggs, nuts, tree nuts, especially tree nuts with oils in them. I wrote bananas over here. I wrote bananas just to make myself remember this. People that are allergic to bananas often have latex allergies associated with them. Okay. And they might have anaphylaxis with that, but if someone tells you they're allergic to bananas, you would put latex precautions into place. I don't know that it's always anaphylaxis, but I just put that there to remind me to say that. Okay. Bee venom, wasp, bees, hornets, snakes, scorpions, all the venoms. When a snake bite, you die from anaphylaxis. That's what kills you. You have an anaphylactic reaction. My son just got home from New York. So that's what kills you. All right. Now, this comes on pretty quick. Comes on very quick. However, what's nice is we can reverse it very quick also. You can get them out of this very, very quickly. So what do we do? Airway, breathing, circulation, always our priority. So our biggest priority is to get rid of the airway constriction, the bronchial constriction. That's our first concern. And the drug of choice is epinephrine. Now, you learned up to this point that epinephrine was a cardiac stimulant used in cardiac arrest. That is true. It is used in cardiac arrest. We give it IV push, and it stimulates the myocardium. This person is not dead. And epinephrine is also a very potent bronchodilator. However, this person is not dead. Therefore, when epinephrine or adrenaline is the generic name for epinephrine, when adrenaline is given as a bronchodilator, it is given in a sub-Q or IM format. And the dose is tiny, tiny, tiny compared to what is given as a cardiac stimulant. And the doctor would order the dose. A lot is based upon weight. But typically 1 milligram is for IV push, is for cardiac arrest. It's like 0.01 milligrams sub-Q. I mean, it's a tiny, tiny dose sub-Q compared to what you give as a cardiac stimulant. We do not give epinephrine IV to a live patient. Push. As soon as they come off that stretcher, you're going to need it because they'll probably kill you. It'll blow their head off. I mean, it will just send. It's still a cardiac stimulant. You can't say, now this time I only want you to work on the lungs. It doesn't work that way. It's still going to cause bronchial dilation, and it's still going to be a cardiac stimulant. But we can't give it IV push and throw their blood pressure out the roof and throw their heart rate out of the roof. So we give it sub-Q or IM, either one. And that will do the bronchodilation part. They still will get tachycardia from it. They're still going to get hypertension from it. But right now we're worried about their airway and their breathing. So they're going to get bronchodilation from it. Okay. Now, so no IV push to a live person ever. People that are on really, really low, people that have a really, really, really low blood pressure, like in the ICU, you will see epinephrine hung as a drip and given IV as a slow, slow, slow drip, but not IV push to a live person. We do not give epinephrine IV push to a live person. Only to dead people. So for lungs, it's sub-Q or IM. Okay. So now we're already starting to reverse the bronchial dilation and the laryngeal being clamped off. Okay, so we're getting their airway open. Once we start getting their airway open, put some oxygen on them, because putting oxygen on a closed airway doesn't help. So we got to open their airway, help their breathing, give them some oxygen. It's caused by a histamine release, so let's give them an antihistamine. The most common antihistamine that you know is probably diphenylhydramine. Diphenylhydramine is Benadryl. And that's given we usually use about 100, for an adult, about 100 milligrams IV push. We do give that IV push. If they're small, it might be 50 milligrams, but we give them a good dose of Benadryl IV push. Okay. It's an antibody antigen reaction. So we need to give them something that stops the immune reaction, stop the immune response. And those drugs are called steroids. Their names typically end in SONE, S-O-N-E, prednisone, hydrocortisone, betamethasone, dextromethasone, when we talked about it in the brain. So we give them a steroid. Hydrocortisone, the trade name Solumedrol, methylprednisolone. Those are probably the most common ones. Solumedrol, Solucortef are the trade names. About 125 milligrams IV push. We want to stop the antibody antigen reaction that's taking place. And the last one is an H2 blocker. Can anyone tell me an H2 blocker? Does anybody know an H2 blocker? Unmute and tell me one.
Propranolol.
No, propranolol is a beta blocker.
Famotidine,
Famotidine. Famotidine. Do you know the trade name for famotidine?
Pepsid,
Pepsid. Now, up to this point, you got famotidine, you got cimetidine, which is not Tagamet. It's Tagamet. And we used to have ranitidine, which was Zantac, but ranitidine's been taken off the market. So you're probably going to give famotidine is probably, or cimetidine are going to be the two that you give. Okay. So they end in adine. And so you think, well, why are we giving that? That's for GERD. Well, your stomach acid is histamine. It's a long histamine. It's a long-acting histamine. But that's what stomach acid is. It's a histamine. So your H2 blockers are long-acting histamine blockers. Where Benadryl or diphenylhydramine is a short-acting histamine blocker, your H2 blockers are long-acting histamine blockers. Therefore, that's what we give them. And once we give them these, we can reverse this very quickly. So that's why the thing that's going to kill them is their airway and their low blood pressure. What do they take? They carry an EpiPen and they pop themselves in their leg and their sub-Q or IM tissue, And that will start to reverse their bronchodilation, their laryngeal edema, and it will increase their blood pressure. And that EpiPen starts to reverse their ABCs. And we get them back. It comes on fast, but we can make it go away fast too. Most people, if they can get treatment quick enough, will not require intubation. We can reverse them very, very quickly. If not, they're going to have to be supported. If we can't clear their airway, we're going to have to put an ET tube in them. If we can't get the ET tube in them, then they're going to have to be criked. I mean, it'll be just like treating anybody else who we lose their airway in. But most of these patients, we can reverse it. So what do we do? ABCs, airway. Can they talk? Can they swallow? If they're coming in drooling or their neck is really swollen out, we know we're having an airway problem. People whose larynx is closed off cannot swallow. They will not swallow. They'll just sit there and drool. A drooling adult is not a good thing. It usually means that there's a possible airway problem with a drooling adult. A drooling toddler's cutting teeth. A drooling adult, airway problem. Okay. Breathing. Do you hear breath? Oops, I didn't mean to do that. Do you hear breath sounds? What do they sound like? If it's bronchial constriction, you should hear wheezing. If there's no wheezing, but they're in distress, that's bad. That means they're completely shut down and not moving any air at all through them. Are they working hard to breathe? Do they have retractions? Are they head bobbing? Are they struggling, showing signs of hypoxia? Sit them up. That'll help them breathe better. Let's get some high flow oxygen on them so that what alveoli are open can have better gas exchange going past them. Get that epinephrine working on them. Monitor the circulation. Check their end organ perfusion, which is capillary refill. That is a C. What is their blood pressure? What is their pulse? What's going on? Do they need fluid support? Typically, if we can get the epinephrine on board, they might not need large amounts of fluid. Of course, we're going to open an IV on them so we can give them other meds if we need it, like the Benadryl IV push, the Solu-Medrol, the steroid IV push. They need an IV, of course, but they may not need liter after liter after liter of fluid. If we can give them the epinephrine sub-Q or IM, then that really kicks in pretty fast, really fast. I mean, within a minute, it will start kicking in. And then help them with comfort. Typically, the Benadryl will help the itching. You will find most of the time when people's hands and feet are itching, and it's really driving them crazy because they're really itching a lot, hot packs work better than cold packs. Break a hot pack. You should have hot packs in your department just like you do cold packs. Or get some really hot washcloths and let them keep putting some hot washcloths or hot towels on them. Hot usually takes care of itching better than cold does. If they like the cold, you can use cold, but hot usually makes them feel better and makes the itching go away faster than cold does. So hot tends to work better. And then try to decrease their anxiety. Let them know that you know what you're doing. Let them realize, stay calm. If you've got a calm family member, let them stay with them. If you've got a hyper family member, may not be the best person to be in there. And reassure them frequently that things are getting better or that you're watching them frequently, but you have to be calm to help decrease their anxiety also. And then client teaching. What are they allergic to? How do they avoid them? How to avoid like substances. For example, if they're allergic to penicillin, cephalosporins, people that are allergic to penicillin are often allergic to cephalosporins. So what are cephalosporins? They're drugs that usually have Kef in them. So K-E-F, C-E-P-H, K-E-P-H. So it's like Kefsol, Rocephin, cefatine. They usually have Kef or Ceph in them somewhere. So if they get put on, Kefsol at home or ceftriaxone or whatever, if they're allergic to penicillin, they shouldn't take those drugs. And you as nurses should know, because I know this is on NCLEX. When you check allergies, you're going to have somebody allergic to penicillin, and then they're going to say, which of these 4 drugs do you question? And one of them is going to be a cephalosporin. You would question a cephalosporin when your patient is allergic to a penicillin, because there's a crossover between penicillin and cephalosporins. So they should know that. This same friend of mine that used to teach peds, her son was allergic to sesame seeds. And every time he would eat sesame seeds of some kind, he would break out. And so she calls me and she says, for having a college educated son that's so smart, he ain't very bright. I said, well, what happened? He goes, she said, I'm on my way to the ER again with him. I said, what's the matter? She said, he went to the Japanese restaurant. She said, you would think he would know that at the Japanese restaurant they cook with sesame oil, but does he know this? Does he ask this? And he said to me, but Mom, that's sesame oil. I'm allergic to sesame seeds. She said, is he that stupid? I said, well, I won't call him stupid, but he should use his brain better than that. So, sesame oil, sesame seeds, these would cross over type things. So and it's like bananas and latex. It's like, what, asking for peanuts and peanut oil that's cooking, most of the time they have signs of that we cook our French fries in peanut oil or stuff like that now, but how to avoid like substances type things. Okay. They should wear ID tags. I'm telling you, people quit wearing the ID bracelet saying I'm a diabetic or I'm allergic to whatever. They have some nice ID bracelets now. They don't all have that big thing that has the same medical alert on them, but they have nice ones. But it would help to know what's wrong with people. Years and years and years ago, they did this big campaign in Charlotte to identify your children. It wasn't allergies, but it was identify your children. And they made all these little tags that you were to sew in the tongues of your children's tennis shoes. And it had your children's name in them so that if they ever got hit by a car, they ever got injured, medic would know exactly who your child was. And everybody in the ER said, why in the world didn't these news agencies ask healthcare providers? Because everybody knows when a kid gets injured, sick, hurt, whatever, the first thing that typically gets taken off or gets lost are the kid's tissues. Why in the world didn't they asked us, we would have told them to sew it on the child's underwear. Because the last thing they're going to lose is their underwear. And if we were cutting the kids' clothes off, we would have got to the front of their underwear and there would have been the tag saying, this is Johnny Smith. He's allergic to sulfa. Or this is his address. Sew the tags on your children's underwear. Don't put them on their shoes. Their shoes are laying at the scene of the wreck, laying at the scene of where you got hit by a car. They're not going to make it into here. And so, there was just really stupid. So, maybe if you don't want to wear a bracelet, then sew your allergies on your underwear. I don't know. Do what you want to do to let us know what's going on with you. They should carry an ANA kit. They should have the EpiPens. They're not the cheapest things in the world anymore because drug companies have found out that it costs lots of money and they can make lots of money on them. We were talking about this over at the school one day and how expensive EpiPens have gotten. And the makers of the EpiPens now say, and you need to find out, I'm just giving you an example. I'm not saying it's okay to do this. I'm just giving you an example. But they said that if your expiration date was in January of 2021, that you can automatically extend it to January of 2022. That they were good for a whole nother year. And because they're so expensive and they found that they're good for a whole year after their expiration date. I'm not saying do it. I'm just saying you might want to check into it if you have EpiPens and find out from the manufacturer, because most of them had sent out in their website saying that they could be extended safely for a year because they're expensive. They've gone up to like $600 an EpiPen. They're expensive. And people don't want them because they're expensive. But if they have anaphylaxis, they'll have them. They're scared not to have them. And then desensitization, which is like allergy shots, where they start building antibodies up against what they're allergic to. And here's my old buddy here. He's got anaphylaxis. Some causes are bee stings, medications, and you can see he's got a pill cutting off his throat. He's got a bee cutting off his larynx. He's got iodine, which I didn't talk about that. Your IVP dye, your contrast medium in the hospital can often cause it. Seafood, and it's not fish. Fish does not typically cause allergies, but seafood, it is the crustacean, it is the shell that has the iodine from the ocean that is in constant contact with the meat. So they have a high iodine content in seafood. You do not have a high iodine content in fish. So fish is okay. It's seafood that is the problem. So here he's got some lobster that's causing him to have whelps and itching on his skin. I didn't talk about those, but those are often causes. So you get the very rapid onset, and they get the sweating, and they're very anxious, and they know something is wrong, and they get a very tightness in their throat, and they start coughing, and they get short of breath, and they get a tingling and an itching in the back of their throat because they feel something's happening back there. They get an itching and a weakness, and they may lose consciousness as their blood pressure starts to fall. So the treatment is going to be epinephrine sub-Q or IM. Either route is considered okay, followed by Benadryl or oxygen. Once we open their airway, put oxygen on them. Benadryl or diphenylhydramine IV push to stop the histamine because it's an antihistamine. Then a steroid IV push to stop the antigen reaction, and then an H2 blocker IV push just as a long-acting histamine blocker. Okay? All right, so it is 10:50. I will see you all back here at noon. We're going to come back and talk about some very specific hypersensitivity and other type of reactions that we see in patients. All right, I'll see you all back here at noon on the other Zoom. Any questions?
Amy,
Yeah.
Kathy is still doing the NCLEX review,
Well, yes,
right?
Kathy is doing the thing, but she will get on the next Zoom. She's going to be her own host because last time we had troubles with getting her to be the host. So you need to go on and sign out, and she will come on about 11. So go run and get a sandwich or something and bring it to the computer. She doesn't mind you eating while she talks at all. And again, she's not going to tell you how to pass the NCLEX exam. She's going to tell you, I'm going to do that at the end. She's going to tell you how to sign up for the NCLEX exam and what she needs you to do so she can verify you as the last step. Please listen to her, because everybody tried to sign up early last time, and it let them sign up early before graduation. And then you know what happened? NCLEX threw them all out. And then they didn't get noticed till 2 or 3 days later. And then they were all mad because other people all got to sign up in front of them. And so listen to what Kathy says. You cannot sign up until after graduation on that Monday. So listen to what Kathy says. She's telling you the rules. You got to follow the rules. Y'all don't like to. Nobody likes to, but you got to. So sign out of here, go in under Kathy, and then after that, sign out of Kathy and come back in under me. Okay? All right. Bye, y'all. I'll be back at noon. All right.